Hello, I'm Valentina Guarneri. I'm Professor of Oncology at the University of Padova, and I'm the Director of Medical Oncology at the Istituto Oncologico Veneto in Padova, Italy. So today we had a symposium focused on the optimal treatment of hormone receptor positive, HER2-negative metastatic breast cancer. And we have discussed the treatment option at progression after first line of treatment. And it is important to remind that this kind of patients may still derive benefit from targeting the endocrine pathway, unless, of course, the situation of imminent organ failure or situation requiring the switch to chemotherapy strategy. We have data now suggesting that we can select on the basis of biomarkers treatment that can provide meaningful PFS benefit in second-line treatment. And also, it is important to remind that we really need to stay on a biomarker treatment algorithm to ensure optimal treatment selection for these patients. So, for our routine practice, the key message is to be ready to offer to our patients SR1 testing, PIK3CA testing, to select the proper treatment after progression on CDK4/6 inhibitor-based first-line treatment.
Hello, dear colleagues. This is Matteo Lambertini from the University of Genova San Martino Hospital in Genova, Italy. I'm here at the EBCC-14 conference, the Menarini Symposium on the latest advancement in the management of patients with hormone receptor positive HER2-negative breast cancer. In my presentation, I've addressed the current ESMO guidelines, particularly for first-line treatment choices and the sort of old-generation endocrine-based therapies for second-line endocrine therapy. Main conclusion from the first-line setting is now very clear that the combination of a CDK4/6 inhibitor plus endocrine therapy should be considered as the global standard of care in this setting. Unless there is a visceral crisis, a real visceral crisis, this is the combination to be offered to most all our patients in this situation. For the proper choice, we need to take into consideration the definition of endocrine resistance and endocrine sensitivity, because this was an inclusion criteria in the CDK4/6 inhibitor trial, and this definition has a strong prognostic value. The second important consideration is that for selecting a second-line endocrine treatment option, this definition of endocrine sensitivity and resistance becomes more complex, because we need to integrate some other biomarkers, because now we have sort of genomically driven endocrine-based therapy for selecting a proper second-line treatment option. In my talk, I've addressed the old generation treatment, and particularly fulvestrant, that has been and is still a potential treatment option in this setting. We have to keep in mind that, as shown in all the post-CDK4/6 inhibitor trial, in which fulvestrant alone was a standard of care in the phase 3 trials, we see that the performance of this agent is quite poor. It's between 1.5 to 3 months median progression-free survival. So it's important to test our patient for different genomic alteration to offer potentially genomically driven option, and unless there is no alteration to be offered, then fulvestrant or the combination of everolimus should be considered in this context.
Hello, my name is Federico Rojo. I'm pathologist at Fundación Jiménez Díaz, University Hospital in Madrid, Spain. I'm here in Milano in the European Breast Cancer Conference to discuss the advances in breast cancer and new evidence about different biomarkers and the biology of breast cancer. We had the opportunity to discuss about ESR1 mutations in breast cancer. ESR1 mutation in luminal metastatic breast cancer is a secondary or acquired resistant mechanism to endocrine therapy that induces a reduction in the efficacy of standard treatments, but retains sensitivity to the new generations of selective estrogen receptor degraders, such as elacestrant. In addition to that, ESR1 mutation in breast cancer is a strong prognostic biomarker in terms of progression-free survival and overall survival. For those reasons, the detection of ESR1 mutation has been incorporated in the landscape of alterations or biomarkers in the diagnosis of luminal breast cancer to assist the management to clinicians of these patients. ESR1 mutations can be detected both in tissue and liquid biopsies with important considerations. First, the time of sampling. after the progression to the first line or subsequent lines of therapy in luminal metastatic breast cancer. Second, good representation of the disease. In a tissue biopsy, sufficient representation of the tumor, and in the case of liquid biopsy, sufficient quantity of DNA circulating tumor DNA. In addition to that, good methods in the laboratory to detect the mutation, both single gene approach based on variants of PCR or next generation sequencing, and in the case of liquid biopsy with enough sensitivity to detect this small amount of circulating tumor DNA that represents the ESR1 mutation. And finally, good quality, good policies in the laboratory to perform the ESR1 mutation testing.